Okay, we can start. Go ahead.
Okay. Let me just get my slideshow set up. Give me 1 second. Okay, can everyone see this?
Yep.
See that? Okay. So we're going to do review of EMS admin ethics. It's kind of like a grab all basket of non-medical things that affect your medical practice. So this is just a review slide on, so I'm going to start with a bunch of review slides and then we'll go through a bunch of questions. So this is for EMTALA. We throw the word EMTALA around a lot, but just to give you a background of where EMTALA actually comes from, um, it is also known as the COBRA law because it was part of this larger law. I forget what COBRA stands for, Consolidated Omnibus Budget Reconciliation Act. And it's also called an anti-dumping law because that's essentially what EMTALA was trying to stop was the dumping of patients. So basically, patients that hospital systems didn't want to care for whatever reason, be it because of insurance status or that they were frequent flyers, abusers of the system, that kind of thing. And they would dump these patients on other hospital systems. And so basically, the EMTALA law was created to say that all hospitals are duty bound to perform a medical screening exam to stabilize patients, that you can't transfer patients unless there's a clear reason. It's either the patient requests it because you don't have the specialty abilities to care for the patient. You have to make sure that the patient is stable, or that if they're not stable, that the benefits of transfer outweigh the risks. And that the receiving hospital accepts the patient. You can't just send a patient without anyone accepting the patient. Furthermore, the receiving hospital has to be able to care for the patient. They have to have the resources that are necessary. Um, oops. Okay. So I got a couple slides on EMS. This just goes over some history of EMS. So EMS started in the 60s. In 1966, there was a Highway Safety Act, which included a bunch of things, but part of it was it gave the U.S. Department of Transportation the power to start developing pre-hospital systems. There was then later the EMS uh, Emergency Medical Services System Act, which provided funding and training. And then the EMTALA law, as we described, that basically put some guardrails around how EMS should function, how the transfer of patients should function. And then lastly, there's a Trauma Care Systems Planning Development Act. And this is to help, this was also government funding to help states to develop trauma systems. So there's a couple of different designs of EMS systems. In New York, we have a combination of fire department and hospital-based EMS. But there are a range in some smaller counties. There's a volunteer model, just volunteers, no funds or anything like that. It can be private, where it's all private ambulance companies. Um, uh, you can have a government-based system where the government runs the ambulance system, and it's separate from their police department, from their fire department, from everything else. Like I said, in New York, we have so for example, in Boston, where I trained, there was Boston EMS. It was separate from the fire department, police, etc. In New York, we have the fire department-based system, as well as the hospital-based EMS companies. There's combinations of those things. And then in terms of the different, so those are kind of like basically the funding systems for EMS systems. And then on top of that, you also have EMS systems that are single tiered or multi-tiered, where there's one type of ambulance or multiple type of ambulances. So obviously in New York, we work in a multi-tiered system. Um, so there is EMS systems typically have a medical director who provides administrative and medical oversight. And med controls can take a couple different forms. It can be direct med control where where there's actually a physician or some sort of provider that's actually in the field, or it can be direct also by phone or telemedicine or other means where the pre-hospital providers can actually interact with the doctor in real time. And there's indirect where it is based on creating standing orders, protocols, etc. So New York's EMS system, they work with both. They have standing orders. So, someone has altered mental status. You are depending on what level of EMS provider you are, you're able to do certain things like a finger stick, provide oxygen, that kind of stuff. And then if you want to do something more, then you have to call for medical control to run it by a physician. All right, so moving right along, we're going to talk a little bit about disaster preparedness. So disaster preparedness has 4 phases. Um, Once a disaster happens, there's going to be the response to that disaster. There's recovery after the disaster has subsided, getting things back to normal. And then there are 2 more planning parts. One is mitigation and prevention. So what you can do to prevent that disaster from happening again. And then the 4th phase is preparation, where you are training, educating, planning for the next disaster based on the lessons learned from the prior one. Within the response phase of a disaster, typically a lot of places use what's called an incident command system. And that is a way of organizing things so that there is basically less chaos. It basically tries to centralize everything under the control of an incident commander. And that incident commander usually has multiple people working under them. For example, there's a couple listed here: public information, safety officer, liaison officer. So someone that kind of just works on just the different aspects of it. So someone that just handles media, someone that just handles operations, someone that just handles safety or security. And in this way, you can kind of centralize resources and deal with the disaster. Okay. So another part of disasters is that there is usually a different way of triaging patients. So we oftentimes use these color codes, red, yellow, green, and black. So red means a patient is critically ill with an immediate life-threatening illness and something that you need to address right away. Yellow is someone that's serious, but they're not immediately life-threatening. They can wait. Green are the walking wounded. They probably can just be sent away and told to, go somewhere else. And black are patients who are dead or who are close to dying, close to dead, and they're not going to be salvageable without intensive resources. So this is another way to think about it: deceased, immediate, delayed, and minor. The key thing that's different here is what you do with these patients. So a deceased patient, you don't do anything. You provide palliative services. An immediate patient, you have to take care of that patient right away. A delayed patient, you might get things started, but you ultimately are allowing that patient to wait. They can be transported later. They can be put off to the side. And a minor patient is someone that it will take days before they start deteriorating, so you can probably send them away. This slide is just to show that patients can change. So, for example, you have a patient that you're assessing and they are not breathing. We're following this pathway here. They're not breathing. That doesn't necessarily mean that you're done, right? You can reposition the airway and see if you're able to get the patient to start breathing. If that's the case and the patient falls into that red category and it is worth it to start, doing more interventions immediately to try to stabilize that patient. If after repositioning the airway, there's still no response, that's the point at which you can decide that a patient is Black. So it's not just your immediate evaluation of the patient, but there can be things that change. Here's another great one. Mental status, where can they follow commands? Can they not follow commands? Something that you might throw in here is like you get a finger stick and you correct hypoglycemia. That patient might change from an immediate response to someone who can be delayed, going from red to yellow. All right. For EMS, I wanted to just review the different types of EMS providers. So there are a couple different names that are used out there. There's a first responder or emergency medical responder. This is someone that has basic first aid training. They may be able to use an AED, but probably not much more. They may be able to do CPR, but probably not much more. There is then an emergency medical technician who has like the BLS certification, but they have a little bit more training. There's next an EMT immediate or an advanced emergency medical technician. These are EMTs who are able to do basic procedures. So IVs, give certain medications, place patients on monitors, and in some cases they can intubate patients or stabilize their airway. I don't see a lot of this EMT intermediate in New York, but what we have a lot of are paramedics. So paramedic is the highest level, and they require, as you can see, many hours of training. And these are the pre-hospital providers that can do a lot more. They're shocking patients. They're not using an AED. They're using, like the same type of Zoll that we use. They are interpreting EKGs, deciding the patient has a STEMI. They're doing advanced airways. They can do BiPAP, needle decompressions, etc. All right. So trauma center categorizations. This is not what the American College of Surgeons, what those levels are. This is more of a generic trauma designation. So you might see like the ACS designation is an accreditation. You have to like be visited by ACS and meet certain criteria. This is more just understanding how a hospital falls within an EMS system. So a level one trauma center is a place where they're able to do the full range of everything. They've got all the specialists. They can provide a very high level of care, a surgical ICU. They tend to be a referral center for a larger region, and they will have residency and teaching and research. A level two is a step down from that. So they will have most specialties, but not all of them. They'll still have them 24 hours a day, but they may not have a research or residency program. They're not necessarily involved in, pushing the envelope. A level three has enough for emergency care. So you can get things started, you can stabilize patients, and usually it's stabilized and transferred to somewhere else. And they've got some specialists, but they don't have all specialists. They at least have the basic specialists like a surgeon. A level four is basically like the ER is it. There is not a surgeon that they can call. There is not any specialist that they can get for help. They're able to, get x-rays and maybe CAT scans and stabilize patients, but beyond that, they're not able to provide the specialty care. All right, criteria for transport to a trauma center. So I'm just going to run through these. These are pretty self-explanatory. So abnormal vital signs, penetrating trauma to the head, neck, torso, or extremities, a flail chest, two or more, so multiple long bone fractures, mangled extremities, pelvic fracture, signs of a depressed skull fracture, neurologic deficits, a bad mechanism like ejection or death of another person in the same passenger compartment, significant extrusion of the vehicle, a pedestrian or bicyclist struck, motorcycle crashes at more than 20 miles an hour, elderly, children, patients that are on anticoagulants, and patients that are pregnant greater than 20 weeks. So ESI, we use ESI all the time. And I think you're probably all very familiar with it. So I'm not going to go into the details. The one thing I want to point out that it's not just how stable the patient is, but it's also how much resources the patient is anticipated to require. So for example, a shoulder dislocation, those patients are stable. They're not necessarily in risk of uh, life-threatening. You could argue that it's limb-threatening, but they tend to be high resource patients because of sedation. So that's someone that would be an ASI 2 and not a 3. But yeah, just note that it's a combination of all these things, not just how sick they are, but also how many resources they are anticipated to require. All right, so a quick primer on billing. So we've got these levels of service. This is all based on CPT codes that are established by CMS, the Center for Medicare and Medicaid Services. And they determine how complicated of a encounter you have. For emergency medicine, we use these codes 99281 up to 99285, corresponding to level 1 to level 5. The old method, pre-2023, relied on how many bits of information you documented, how many bits of HPI, review of systems, medical, family, social history, and exam findings. That has been done away with, and the new guidelines since 2023 focus on how complicated the medical decision making is. So it's straightforward, low complexity, moderate complexity, um, detailed history and exam with moderate complexity, or very high complexity, comprehensive histories and exams. So it's not like as much of a point system as it was before. It's more just holistic. Beyond those 5 levels, there's also critical care. Critical care is above that level 5 billing. And critical care, the definitions of all of this has not changed in the 2023 revisions. So CMS says that critical care is defined as an illness that acutely impairs one or more vital organ systems, and if it's not treated urgently, it can lead to significant worsening of the patient's condition and can be life-threatening. In order for critical care to receive any billing, it has to start at a minimum of 30 minutes, and only certain things count in that 30 minutes. So time spent at the bedside, interpreting test results, talking to specialists, discussing options with a family. It does not include procedures that you're billing elsewhere. So if you're getting a line in, intubating the patient, managing their ventilator, that kind of thing. Sorry, I take it back. If you are separately billable procedures like intubation, central lines, placing the IO, chest tubes, those are not counted. Um, Teaching is also not counted. But the things that are counted are kind of like the procedures or actions that are part and parcel of evaluating and resuscitating the patient. So placing an IV, putting an NG tube in, managing their ventilator after they've been intubated, that can all be included in the critical care time. All right, a thing on minors. So there minors in the country, in the US, are defined as under 18. Um, and they are treated differently when it comes to medical decision making. So for the most part, you have to have a consenting adult. Should be parents or a legal guardian, but depending on the situation, it could be other family members, like a foster parent, someone else designated by the parents, etc. There's also emancipated minors, and emancipation can be for several things. The common things across most states are anything related to pregnancy, anything related to sexually transmitted infections, and anything related to mental health or drug or alcohol substance abuse. Uh, when minors are seeking care for those things, they are considered to be emancipated and they don't need someone else's consent. There is this idea of mature minors, which is basically saying that maybe 18 is not necessary. Like you can start at a lower age as long as they show maturity in decision making. New York does not have an age that they've set, but certain states do set an age at like a minimum age at like 14 or 15 or something like that, where you can start uh, factoring how mature that minor is. All right. So patient satisfaction scores, why is it important? So we care about the patient satisfaction scores, not just because we want to make the patients happy, but it's also better in terms of compliance with the treatment plan that you suggest for the patient. It helps to reduce malpractice risk. It improves morale. It encourages health-seeking behavior from the patients. And financially, for the stability of your practice, it's good for your physician group. What drives patient satisfaction? So probably the most important thing is communication between staff and the patient. Um, the next most important thing in most studies is usually wait times. Other things that patients are looking for when they're thinking of satisfaction is they're thinking of empathy and compassion. Patient callbacks are another good way of improving your satisfaction scores. All right, so we're a couple more slides. Safety events. There are. This is a rubric for how to categorize patient safety events. So an adverse event where there's actual harm, a no harm event, the safety event reached the patient, but there was no harm resulting from it. A close call, also known as a near miss or a good catch. It almost occurred, but something prevented it. And then unsafe or hazardous conditions, conditions that don't necessarily not necessarily that harm is happening, but rather that it just increases the risk of harm. Some adverse events are not preventable. For example, an allergy that you didn't know the patient had an allergy. Sometimes it's, a patient passes away after a cancer diagnosis, and that's just the natural history of that disease. Sometimes they are preventable. Those are the things that we care about the most, obviously. And that's where if we do something or we don't do something, it can result in some sort of harm to the patient. And a sentinel event is an adverse event that leads to a serious poor outcome or death. These are we call them sentinel events because we think of them as, this was a really big case or big error that might indicate that there is something systematically wrong that we need to fix. So, four basic principles of medical ethics. I just wanted to define these things. Beneficence is doing what is good for the patient. Autonomy is respecting the patient's rights for self-determination. Non-maleficence is doing no harm. So beneficence and non-maleficence kind of go hand in hand. You want to do what's good, but you also want to do no harm or do the minimal harm. And then justice, doing all these things in an equitable manner. So these are four elements of negligence. And we think of this when we think of malpractice. So in order for an action or behavior to be considered negligent, we have to be able to determine that that person had a duty to perform whatever that action was with reasonable care. That that person failed to perform that duty that a reasonable similar practitioner would have done, that some damage or injury occurred as a result of that, and that there is a causal relationship between the failure to perform the action and the injury. There's also the idea of willful misconduct, in which case it's someone willfully, they knowingly do something that injures someone or that is likely to injure someone. So that's different from negligence in that this is more intentional. Negligence is more of a violation of the standard of care, but it's not willful. It's not intentional. Not with the intent to harm the patient. So those things all feed into medical malpractice. And in order for there to be a malpractice claim, this is what they're looking for, those four components of negligence. So they're saying they're looking that a duty was owed, that that clinician had a duty to do something, to care for that patient. That duty was breached, that that person did something that did not meet the standard of care for that patient. There is a connection between that breach of duty and the injury, and some sort of injury or damage occurred. All right, physician impairment. So physician impairment is when there is something causing the physician to be unable or unwilling to safely practice medicine. It can be health related, it can be psychiatric, substance abuse related, and it has to interfere with that person's ability to practice medicine. Impairment is hard to recognize, but you might notice it with tardiness, missing shifts, irritability, medical errors, personality changes. So if there is a physician that is impaired, it is you as a physician, as that person's colleague, you're legally required to report this to your superior or a health program, a physician health program sponsored by the states. This goes together with the ideas that we talked about before of beneficence and non-maleficence, that that person's patients might be harmed, and so you have to act in a way to prevent that harm from happening. Okay, AMA. When a patient decides to leave AMA, there's a couple of things that you have to do. You have to assess whether or not the patient has the ability to make an informed decision. You have to know, please note that this is decisional capacity, not competence. Decisional capacity is like, can they make a medical decision? It's not competence as in like, are they able to function independently? That's what a court decides. So you have to be able to assess that they can make an informed decision. You have to explain the risks of leaving AMA, document why they want to leave AMA, and additional things that you should include in your documentation when someone's leaving AMA is the nature of the discussion, the diagnoses you thought about, alternatives that you offered, um, efforts that you made to get other people to help out in the decision making, explaining any lab abnormalities or inconsistencies in documentation. So any results that you have so far. If a patient refuses to sign, they can refuse to sign, you just document that. And then you always want to document return precautions. Just because you're discharging a patient AMA doesn't mean that you don't do the standard things that you do for a discharge. So if you think someone needs a prescription, you should still be doing, providing that prescription, documenting the return precautions, et cetera.
I think, Tim, that's a super important thing to point out, that AMA basically absolves you of not doing your A number 1 plan, but it doesn't excuse you from doing the next best plan that meets the requests of the patient. So someone that you're admitting, say, for cellulitis or say pyelonephritis, that you want to give IV antibiotics, and maybe you think they're not so well enough to go home, but they can't stay. Maybe they have childcare issues or whatever. If you send them out and don't send them with antibiotics, doesn't matter that they signed AMA, it's still malpractice. You should send them with the next best thing, which would be an oral antibiotic. And
Right.
like you said, instructions to return if the situation changes where they can stay or they get worse.
Right, right. You have to do your best given the circumstances.
Yeah.
Okay. HIPAA, we hear a lot about HIPAA. You do lots of trainings about HIPAA, I'm sure. Or at least I do. I'm guessing you guys have to as well. But basically, there's two major parts to HIPAA, or three parts. But the two big parts of it is there is privacy of the medical records, and we have to respect that privacy. So that's like, in like who we talk to, getting permission before you talk about medical stuff. Um, the second, I kind of categorize this as part of it, is that health systems have to have systems in place to maintain that privacy. So that's like passwords, not sharing your password, rotating passwords. I think for us, if you have got a password of sufficient length, then you don't have to rotate the passwords. But there's all these, you can't plug in a USB drive into your hospital computers, like all these things to protect that privacy. And the second part of it is the portability of, sorry, not portability for health insurance, but the transfer of those health records, like how that is being exchanged. So, that's where you have to have forms to sign to say that I consent to my information being shared. So that's all belongs under this law, the HIPAA law, from 1996. Um, there are certain things that are protected. So communication between healthcare providers who have a direct patient care responsibility. So that means like when you call a consultant, you're talking to someone that has never seen or had any interaction with the patient. That's covered under HIPAA. You're talking about private information, but it is for the patient's care. That person you're talking to has direct patient care responsibilities now that you've consulted them. The second part of it is this information is all shareable with the insurer for billing and payment purposes. Um, Exclusions for organ donation. I'm actually going to skip going over this. I think this is pretty self-explanatory. You guys can read it when you go through the slides in your advanced directives. So what is an advanced directive? It's some sort of document. In New York, they call it the MOLS, the Medical Orders for Life-Sustaining Treatment, that pink or red, pink piece of paper. And it is a document that has to be signed by the patient when they still are able to make medical decisions. And it basically outlines decisions when they have lost the ability to make the decisions. It outlines what they would like done, and it also may outline who who can make decisions for that person. Now, there are situations where we don't have that, and that's when we have to rely on what's called a surrogate decision maker. So when the patient has lost their ability to make decisions, we go to the surrogate, and there's a certain priority. So if three people show up, the first person you have to give priority to is the spouse, the active spouse, not an ex-spouse. Any children that are of adult age, parents, adult siblings, and other relatives. And it has to be, it goes in that order. All right. I think this is the last bit. There's just a little bit of review of stats and hierarchy of evidence. I'm going to start from the bottom here. These are the types of studies that you may need to read and base your practice upon. So the lowest level is a case report. It's just exactly that. It is a report of one case of a patient. Case series is the same thing, but with a number of patients that have something in common, either a similar treatment, a similar exposure, um, something that ties them together. A cross-sectional study is observational, collected from a population sample, and you basically analyze data from that sample at one point in time. The next level up is a case control study. That's when you match cases and controls. So patients with the disease to patients without the disease, and you match these patients in order to control for certain variables like age and gender and that kind of thing, that might be confounders. And then you try to see what is similar or different between those the cases and controls to figure out what the cause of a disease might be. It's done retrospectively. A cohort study is done prospectively as longitudinal. It is a group, so it's kind of like the cross-sectional, but you do it over time. So you get a group of people that are similar somehow, all born in the same year, all graduated from the same class in residency, and you study them over time to see how uh, to see what differences arise. A randomized control trial. You guys probably know a lot about randomized control trials, but basically you have to randomly allocate people, and that's the best, but that random allocation is the best way to eliminate the effect of the confounders. And you control by having a group that is exposed to something and a group that isn't exposed to something. And then there's systematic reviews and meta-analysis. A systematic review is when you have some sort of systematic way of basically pulling in other studies. You define a way of choosing studies that you want to review, and you review them. And a meta-analysis is like a randomized control study, but it is a summary of multiple randomized control trials. So you pull multiple trials together and you combine the data. So biostats, there's a lot here. I'm just going to go through the definitions. So mean is the average. Standard deviation is the variability from a mean. So if there's a wide standard deviation, it means there's a lot of variation within that sample compared to that mean. I'm going to skip a couple of these things. Type 1 error. That is when we incorrectly reject the hypothesis, the null hypothesis. Type 2 error is when we incorrectly accept the null hypothesis. So type 1 error refers to, so alpha is the probability of a type 1 error, beta is the probability of a type 2 error. The power of a study is the probability of correctly rejecting the null hypothesis. The way that you can increase the power of a study is by increasing the sample size or increasing the effect size. So the sample size is, how many people you're including. The effect size is how big of an effect you're looking for. Are you looking for a 10% reduction or a 20% reduction? and also increasing the precision of the measurement. The confidence interval is the range in which a real mean is expected to fall. And then there's a bunch of statistical tests and how you use them. So you tend to use a t-test when you're comparing the means of two samples. ANOVA is the analysis of variance. It compares the means of three groups. A chi-square is when you're comparing two percentages or proportions. So not means, but percentages. I'm gonna skip the other things because I think we talk about predictive value, sensitivity, specificity all the time. Okay, so that's it for slides. I'm just gonna run through a bunch of questions now. Let's see. I only got a couple people here. That's okay. But if you, Kevin, Ariana, if you guys have an answer, please shout it out. So in 1966, the Department of Transportation was given the financial and legislative authority to develop EMS by which law? Was it the Emergency Medical Services for Children program, Emergency Medical Services Systems Act, Highway Safety Act, or Omnibus Budget Reconciliation Act?
Was it B?
Uh,
Emergency medical services
Close. It's C, the Highway Safety Act.
highway.
Yeah. So that's the first slide, just a little bit of a history lesson. Okay, EMTALA was passed as part of which? Which was the larger law? Consolidated Omnibus Budget Reconciliation Act, False Claims Act, Federal Food, Drug, and Cosmetic Act, or the Patient Protection and Affordable Care Act?
Think it's A.
That's right. So what's the other word name for A? Cobra.
Akron. Oh,
Okay. So which of these scenarios is an EMTALA violation? You know what? If you guys don't mind, Kevin and Ariana, I'm just going to have you guys alternate just so that we can keep on moving along. Okay. So you guys kind of already started alternating. So Kevin, this one's for you. Which of the following scenarios represents an EMTALA violation? A patient with belly pain and a seatbelt sign after MVA requests transfer to another hospital, understands the risks and the hospital's duty to treat. A pregnant patient in labor is transferred to another hospital after the examining physician determines that delivery is not imminent. A tertiary care medical facility refuses to accept a burn patient because the inpatient beds are full. A triage nurse reviews a medical complaint, determines that it's not serious, and directs a patient to another hospital that will take their insurance. Which of these is a violation of EMTALA?
So I'm in between C and D. Is it refuses to accept a burn patient? Would it be D?
That's right. Yeah.
No.
So C, it's not C because the beds are full. One of the tenets of EMTALA is that the receiving facility has to have the resources to care for the person. So if their beds are full, they actually don't have the resources to care for the patient. So yes, it's absolutely D. It's because the triage nurse is not performing a medical screening exam. That has to be a provider. So they can't determine that, like they haven't examined the patient, they haven't done anything else, they're just looking at the complaint.
So Tim, if there was an APP or a PA or an NP in triage, could they do that?
Yes, as long as they actually assess the patient. They can't just read the chief complaint and say go somewhere else. It's that first thing. The examining physician determines delivery is not imminent. They actually evaluate the patient and determine that there is nothing life-threatening, that they're stable.
So a medical screening exam.
Medical screening exam is the minimum. Yeah. It's actually not 100% clear if a nurse versus a provider, but most people settle that a provider should be the one doing a medical screening exam. Okay. All right. You're conducting a research study comparing the heart rates of two groups of senior residents while they're taking their mock emergency medicine and service exam. One group will take a 2-week course, the other won't take a course. You hypothesize that taking the prep course will have a lower heart rate when they start the exam. You're only taking one measurement of the heart rate. Which is the best test to use for your study?
I always get biostats questions wrong, but I think it's D because it's comparing two groups and one outcome.
Yes, it's comparing two groups, not just two groups, you're comparing the mean of two groups. So, for example, a chi-squared compares two groups, but it compares a proportion or a percentage, whereas the student t-test compares um, a mean. And then the one-way ANOVA, a C, is comparing several means, 3 or more. So yeah, you're correct. It's student t-test. Okay. Which of the following represents the largest percentage of medical errors in the ED? Labs, meds, radiology, triage.
Um, was it the largest percentage? Would that be triage errors?
No.
No, medication errors?
Medication errors.
Yeah.
Yeah. Medication errors are by far the most common. And if you think about it, it's because there's so many ways that it can go wrong. It can be you ordered the wrong thing, ordered the wrong dose, the pharmacist approved the wrong thing, you didn't check for allergies, they picked up the wrong thing, they administered the wrong thing, they administered it the wrong way, IV versus IM, there's just so many things that can happen in medication error. That's why it's the most common. Okay. 2 planes crash at an airport with injuring hundreds of people. You're part of the disaster team and you start using the START protocol to triage patients. Your first patient, Ariana, your first patient is breathing spontaneously with a rate of 45 breaths a minute. What color would you give that patient? Black, green, red, or yellow?
I would say red.
Yeah, I agree. It's red. So definitely not black. The person's alive. They're breathing on their own. Definitely not yellow. This can wait. It's red. They're breathing at 45 breaths a minute. I got to do something. Definitely not green. Okay. So this is a consent for minors. Which of the following scenarios, Kevin, needs parental consent? A 14-year-old girl with vaginal discharge and requesting testing for STIs. A 15-year-old boy who's asking for cocaine and alcohol detox. A 16-year-old girl who's 12 weeks pregnant with belly pain, or a 17-year-old boy with arm numbness.
Would it be the arm numbness?
That's right. So that one needs parental consent because they don't meet any of those emancipation things. So sexually transmitted infections, pregnancy-related things related to substance abuse and mental health. Those are the things that don't need parental consent.
Wait, for if in this situation, if this 16-year-old girl, if they like ended up having like appendicitis or something, then we have to go back and contact the
No.
family, or because they're pregnant now, anything related to the abdomen is.
Yeah, not even related to the abdomen. If because they are pregnant, they are considered emancipated. They can be treated like an adult. So even if that 12-week pregnant person presented with an asthma exacerbation, they're pregnant, they can be treated like an adult.
Thanks. Thank you.
So a 40-year-old man presents with chest pain. Shortly after arrival, he goes into arrest. No advance directives. Which family member takes priority in being the surrogate decision maker? Adult child, parent, sibling, or wife? Ariana?
I think wife.
That's right. So wife, spouse is the highest priority. For a successful malpractice settlement against a physician, which of the following is one of the 4 legal elements that has to be proven by the plaintiff? A breach of duty, ethical misconduct, malfeasance, or poor documentation?
Is it malfeasance?
No,
No.
close. So malfeasance is doing harm,
Mm-hmm.
and non-malfeasance is not doing harm. That is more of like an ethical tenet. But for malpractice, we're looking at the four things that are used to define negligence.
Like a breach of
Breach of
duty.
duty. Yeah, exactly. So breach of duty meaning that it was your duty to care for the patient. Like, because of EMTALA, you're responsible for the patients in the ED. That's your duty. And breach of duty, you did not meet that duty, meaning that you did not perform the standard of care for that patient. And then there's the two other parts for malpractice are that there was an injury and that your breach of duty, the fourth thing is that the breach of duty was a cause of that injury, that there's a causal relationship. Okay, so a critical patient is transported by an ALS crew. You speak to the senior-most member to get a sign out. Which of the following is the most senior person in the team? An advanced emergency medical technician, emergency medical responder, emergency medical technician, or paramedic?
Is it paramedic?
That's right. So paramedic is the one, if you remember, that has 12 to 1,800 hours of training. It's a good 6-month course. All right. Which of the following elements of a hospital emergency operations plan involves the activation of a hospital incident command system? Mitigation, preparedness, recovery, or response?
Is it response?
That's right. So during the response, that's when you have to activate the incident command systems to deal with the barrage of information and requests and whatnot. Okay, so this is a similar question, Ariana, to your last one. This is the same thing. There is a automotive plant explosion, lots of injured people. Your first victim is unconscious with significant head and facial trauma, no spontaneous respirations. What do you do next? Do you assign the patient a black tag? Do you intubate them? Do you oxygenate them, or do you reposition their airway? Sorry, oxygenate with a BVM or reposition the airway?
A, black tag.
Close, but not quite. This is one of the ones where they may be black, but you can do one or two things to see if they really are a black tag. You can try again?
BVM.
Close. So it's reposition the airway. Once you're doing BVM for a patient, there's a high chance you're gonna have to intubate them. But if you just reposition the airway and they start breathing spontaneously, then at least that person is able to breathe on their own, right? And can be made a red tag. So that's the difference between C and D. If you reposition the airway and the patient responds and they're breathing on their own, that person, won't need those extraordinary measures to stay alive. Which level of trauma center is fully equipped and staffed by an emergency medical medicine provider, but is without 24-hour coverage of specialty and surgical services? Trauma level 1, 2, 3, or 4?
Is that trauma level 2?
Close. That's trauma level 3.
3.
Trauma level 2, you should have 24-hour, but you won't have all the specialties. You'll have at least a surgeon, probably ortho, some of the big ones, but you might not have the more specialized ones.
Okay.
All
But
right.
someone will be there 24.
But there's at least a surgeon there. Yeah. The difference between level 3 and level 4 is an EM doc, and that's it. oftentimes when you're working those places, you're also like catching babies upstairs and doing codes on the inpatient floors, but that's besides the point. All right, I'm past my time. Thank you guys for your attention. There's a bunch more questions here in the slide deck. Oz, I should just share it with you or?
Yeah, you could share it with me. That'll be good.
Okay, I pulled these from Rosh, and Rosh has a lot of the really good explanations to accompany all of this stuff. So yeah, you guys can also get the questions there.
Thanks so much, Tim.
No problem.
Nice
don't-
job with a tough assignment.
No, that's okay. It's yeah, it's a very like disparate field, like ethics and
Yeah.
EMS, you know.
Thanks, Tim. Appreciate it.
My pleasure.
Have a good night.
Thank you, Dr. Tim.
No worries. Take care, man.
Y'all want to take like 2 minutes or power through? What do you want to do?
Anybody got a pee?
Bio break, stretch legs.
Yeah, we can. Let me pause the recording.
Or maybe,
All right. Next up is Dr. Garg on test taking strategies. Dr. Garg, the floor is yours. Thank you.
awesome. Thanks, Mike, and thanks everyone. So today we're going to talk a little bit about strategy. How do you improve your test scores? So wanted to just give a shout out to our crew. It's always a incredible feeling being able to be in this position where you can help shepherd the next generation of physicians forward, and we love our family. All right. I see Kevin and Ariana here. I don't know, would you consider yourself good test takers? In the past, I've done this with an audience response system so that, I just think about it. I don't know, have you ever been to a talk on test taking strategies?
I haven't before, no.
Okay. All right. So I give this talk also to medical students. So it's kind of really both like med students and residents. But the reality is the key to what we're going to be doing today is really like thinking about the test question, breaking down the science of the question itself, also kind of looking at the answer choices. And so there'll be something that you could know potentially. There'll be something that you'll look at and like, I'm not really sure what that is. So do you remember this from med school? Lesion along thoracic nerve causes?
Would it cause like serratus anterior?
Yeah, and what is that? Do you remember what they call that? It's not E, it's not winged victory, right? But it's like, right, it's like winged scapula, right? That, right? Winged victory is the Nike of somatography, which is a very famous sculpture. But one of the tricks here, and this is what we'll get to, is that if you are the test creator, if you throw a term out there that's like a buzzword, you can often catch somebody if they're not paying close attention. So that's something to be mindful of. So let's talk a little bit about my background here. I want you to know that test taking itself was not necessarily something that I felt very, very strong with. Yes, I know that I'm in this particular position. And now, over many, many years, I feel like I've been able to be a content expert. But what I have been able to do over time that really helped me understand the science better was I wrote questions for USLMA steps 2 and 3. And I got to tell you, it's like 100+ page book that you have to like read in order to kind of get through that. And then, of course, doing board review questions for residency and attendings, and then certainly I've recertified my boards. All right, but the reality is, just like everybody else, I think a talk like this could probably help you about 5 to 15% just by understanding some techniques. And of course, as always, rooting for you all to succeed. So, outline. Let's talk about test takers, good test takers, bad test takers. We'll have a little fun with this. I've got just some kind of silly graphics here. We'll talk about the questions and answers. We'll talk about an approach to success, and hopefully we have a little fun with this. Okay. All right. So great test takers. One of the things that I actually, when I have a longer version of this talk where I have a phenomenal test taker, and we did 10 questions together. And so we kind of just opened up, we both didn't know the answers. We kind of opened up the recording and just said like what it was, what we were thinking. So we would both read a question and then we would both answer. And then we would explain our justification as to why. And one of the things that really dawned on me with great test takers is that there's often a very simple way of thinking. There's something that's almost like this little part of the test question jumps out at them. And it can happen from them understanding either the syntax logic of the question, pattern recognition possibly could be another reason. They just understand what the author is trying to get at. And so for them, it's literally as simple as finding X and there it is. All right. So they have a great system. They're committed to their system. You know, one of the things I thought to do when I was in training was just have all these materials. And then I would review them. I rarely had a chance to review them all to a multiple degree, but instead less materials, reviewing more often. Now, here's the thing. There's only a finite number of questions you can have in emergency medicine. So if you're reviewing a ton of questions, and then more importantly, you're reviewing the answer choices, that can really help somebody and really get you profoundly doing this. So, you know, we have peer questions. We've got our Roche review. There's the 1,200 questions in emergency medicine. These are, I think, are great resources. If you've gone through all of those, there really, really aren't that many more ways that they can ask different types of questions to you. Another thing that you really do is they combine board studying with their regular studying. So as you're reading up on, say, an interesting case, you might do some questions that are related to that organ system. So cardiovascular, let's do some cardiovascular questions. They have a really good routine based with them too. Now, what about bad test takers? Trying multiple systems, more materials, fewer times reviewing the material, reviewing questions without exploring the wrong answers, not studying at all for the boards, and then spending over 50% studying in cram mode. Our brains aren't really wired to do it that way, or certainly not to have long-term memory when you're in cram mode. All right. This is probably less relevant for us now, but I mean, interestingly, UAssembly STEP folks, I actually was lucky enough to work with some of these guys early on and helped in a couple of like forums and chats and met them, and they offered me a job when I was in med school. But I was like, you know what, I'm going to be a doctor. I think that's better. So that was really better for me. So, all right, what are we talking about here? We're talking about practice, right? So the key here is to make sure that we are practicing all of these different strategies. Okay. All right. I just think that McConaughey is hilarious, and so anyway, I'm showing you some funny pictures here. This was when my daughter was like trying to get my attention, and one of the things that in this test taking talk that I want to make sure that we get it is like you focusing on the right way of approaching this. So let's talk about what's the right way to approach this. Let's take a look at question and answer anatomy. The question stem is the beginning of the question. You have a correct answer and you have 4 wrong answers. Maybe even one of those wrong answers is kind of a gotcha answer. And I'll tell you that the exam writers, they get super excited about the gotchas. In fact, I can tell you as somebody who's written exam questions, when you're sitting there and you're like, oh yes, I've got this perfect wrong answer, you get really, really jazzed up about that. All right. So let's talk a little bit about obvious questions and answers. So here are the types of questions you might encounter. One is a concept question. So it's something that could potentially be figured out. Another is a fact type question. And these are like either you know it or you don't. So I'll give you an example of that. I may or may not have had the question on my boards about like the life, like how long does aspirin essentially neutralize the platelet or essentially inhibits the platelet. And so you either know that or you don't. You may or may be able to eliminate some of the answer choices, but the reality is you just probably won't know it. And then they have like pictorial, which often you can get the answer without even looking at the picture. And I can tell you historically, the pictures were pretty bad. Now they're actually really, well, they're much better now. Okay? there's calculations, and one of the big challenges here that I've seen trainees do is that they spend too much time on a calculation question. And if it's just that much time, it might be something better for them to just go forward. And then also remember that there's a good percentage chunk of questions that are research questions. They're just there, they're worded in such a way. And so I remember distinctly, I was taking one exam and I got 3 different questions that were, young 2-year-old virus, and there were about 3 different ways that they were phrasing it. And so I had the same answer for all 3 of them, and I think it could have destabilized me, but because I was like, oh wait, did I get this wrong? Am I supposed to choose something else? And I was like, no, these are research questions. They're trying to find out the right way to phrase this. Okay, so when we analyze questions, understand good questions are written in the affirmative. At this point now, you should not be getting questions that are written in the negative, meaning all of the following except. That just should not be, and it's not going to be what you're going to see on our boards. Buzzwords and stereotypes do run rampant. If a patient has some sort of a flag or something kind of jumps out, don't ignore it. And then understanding like the question syntax or the syntax logic is really, really important. So, obviously some of the buzzwords that we know, worst headache of life, right? What do you think of? You think of a subarachnoid hemorrhage, right? Blue sclera, right? You think about osteogenesis imperfecta, right? So those are the things that kind of come to us right off the bat. So if you hear those, that's where they're trying to lead you. Unfortunately, there are also stereotypes, right? Patient from India. Well, then unfortunately, one of the things that the person might have is TB, right? So that's something to just consider. Just put it in your background knowledge. I've talked a couple times or mentioned a couple times syntax logic. Let's really break down what that is. So that's the hallmark of good test takers. And really what it is, it's paying attention to semantics and also just logic. Like if they're showing me this, then this is what they're trying to get me to answer. Usually folks who are really great at syntax logic, they're very well read. And I would advise people that if you have like a writer that was really great. So growing up in Michigan, Mitch Albom, I love sports, but Mitch Albom was like this phenomenal writer. And so just reading his passages and his like pieces was really great. So it just kind of helped me both like make my love of sports, but also my just like love of reading really great. So that's one of the ways that you can kind of help yourself with reading. And it's not a terrible thing to do. Every morning, I'll read the New York Times like daily blast that comes out. And so that kind of one keeps me up to date on what's happening in the world, but then also just kind of gets my mind going about what good writing is. So yeah, read professional news and some good literature. All right, here's a challenge for you. If you have a pictorial question, if you do the 2 things, these 2 following things, I think you will be able to often solve what they're, the answer, even maybe before you're trying to see the picture or even after you see the picture. So the first question is, who is the patient? And the second is, what would they want me to know? Okay. So I want you to apply that as you see this. Okay. So I don't know, Kevin or Ariana, if you want to take a stab at this, or Mike, or I don't know, but if you take a look at this, like, who is this patient? Is it an adult? Is it a child? Male, female? Is there some sort of idea of who this could be?
Looks like a child.
Okay, great. So it's a child, right? What do you think? I mean, what do you see in the lung fields?
Like diffuse bilateral opacities, haziness.
Right. Okay. Perfect. Right. So maybe you didn't know what the answer to this question was, but now if you've answered those 2 questions, who are the kids who have really bad lung space or lung disease that they would want me to know about?
Like a cystic fibrosis patient.
Boom, you nailed it. Exactly. Right. That's what this is. And so if you ask yourself those 2 questions, who's the patient, like demographically, what would they want me to know? You can often get yourself to get the answers. And that's exactly what it is. And you can imagine what the test question is going to be, right, Ariana? It's going to be like, this patient presents with, fever, sputum, and then they're going to ask you, what type of antibiotic treatment might you want to do? And so then that the jump would be, okay, it's a patient with cystic fibrosis. I'm going to have to cover Pseudomonas. And so then you would want to choose one of your antibiotic choices to have a anti-Pseudomonal, Pseudomonal coverage. Excellent. All right. So long stem questions. So this is actually where I think emergency medicine folks have a real problem, because we get distracted with our, ADHD. We're like squirrel, like what's going on, right? So you really have to focus, okay, on these long stem questions. And I think thankfully in our boards, they're not as long stem as they were in like step 2, but it's something that's there. And one of the ways that I can often focus myself is I'll read it as I'm trying to teach somebody. Or alternatively, I'll look down at the absolute bottom, and there'll be like the key question that they want you to ask, like what's the first step of management, or the patient has this. And so there's a lot of times where I'll be reading the entire stem, and I was like, oh yeah, this patient's got methemoglobinemia. And then you get down to the bottom and it's like, this patient has methemoglobinemia. What's the next step? Would you do? And you're just like, oh man. So I would just say sometimes if you got that long stem, if you can peek forward and maybe even look at what the final like question or directive is, that can be something that can be very helpful to you. All right. So you need to know what they're asking, what the answers are. So, I mean, sometimes I'll even do like a quick preview of the answer choices. But the question and answer choices, that can actually help you on these super long stems. But if you find your mind wandering and you're just rereading and rereading and rereading the stem, then you're actually killing valuable time. All right, calculation questions. One thing I would tell you is make sure you check units. But then I would also just say don't spend too much time, because I can often find people that like they'll just blow all sorts of time on calculation questions. And there aren't that many equations in emergency medicine, really. They might be asking you specifically to calculate osmolar gaps, or they might be asking you about an AA gradient, or they might be, right? Like there's not really too many things, right? There's the pseudo hyponatremia with sodium. There might be a calculation that you might consider for like acute versus chronic respiratory acidosis in that formula. But reality is there's not that much out there. So if there's something like that, I want you to just be mindful that you could probably take a look at what these equations are, so you can get a clue for what might be coming at you. Okay. All right. Remember, research and experimental. Don't get hung up on this. Sometimes it'll be the same question multiple times with slightly different answers. So just know that that's coming, and that's one of the things you have to be thinking about. All right. So I talked about these. These are the gotchas or the destabilizers. Okay. These are, and this actually requires some really good, like extra kind of deep look into this. Okay. So I got a patient here, a 47-year-old patient with acanthosis nigricans presents with. So you sit there and you're like, acanthosis nigricans, like what is that again? And often they might just be saying a patient, who is of a darker skin tone, who's coming in potentially with like an associated diabetes. Like that might be the only thing that they're trying to make reference to. But if you see that, it can really throw you off. So one of the techniques I would tell you is, as you're reading through test questions, it's really good for you to have your own file. And I would just say even put it on a computer and say, hey, okay, I've seen this, and what is this? And so you put it down on the left side, you define it on the right side, and then the third column might be like 3 facts that you can have about that particular thing. Okay. So we'll just pile this in our group of destabilizers or gotchas. Okay. All right. Okay. All right. What about some final answers? I love this. I love this whole meme. All right. When analyzing answers, do you understand what makes the answer wrong? And then here's the thing, right? You got to answer, because you don't get, there's not like partial credit. There's not, if you don't answer it, then you get it wrong, right? So you want to get an answer choice. So can you eliminate answers to improve your chances, right? and then watch out for the killer gotchas. So it's all about answer analysis. So let's take a look at what makes an answer wrong. Okay, so if part of the answer is wrong, it's wrong. The answer is unfamiliar, it's typically wrong. Often if the answer is too wordy, it's wrong. And then, not always, but in most cases, any type of extreme answer that has all, none, always, they tend to be wrong. Okay. Additional things that tend to be wrong answers. Anything that you think is cutting edge, right? Something that might be a conversation topic that you might be talking about at a journal club. That, not like when you're looking back at old ones, but when you're talking about like a brand new article, like that's unlikely to represent itself in a board's scenario. There are things that are like wrong from the past and they're old and they're wrong, right? So, you know, I can there are things that I can think about like way back when where they're talking about decontaminating people with insects, and way back when, you know, there's a medication quell that used to cause seizures or whatever, so that was wrong, like because we have better options now. So but it's still just like always something that I see there as an answer choice. And then anything that's like a negative healthcare behavior, like ultimately you don't want you want physicians to be acting professionals, serving as good role models. And so that's something too. It's unlikely that you're going to have something that's a negative healthcare behavior. So for example, like not giving a patient pain medications because you think the patient has, you know, a substance use issue, a disorder. And so you're trying like, but that's just never going to be an answer choice. And that's what's important to remember. EM is an active specialty. So most of the time, right, correct answers are emergency medicine physicians intervening. There are a few rare exceptions to that. So like the patient who maybe had an MI and then has now gotten thrombolytics and is reperfusing and now has like a, you know, idioventricular rhythm, and it's asking you to like, do you want to extinguish that with some sort of a ventricular medicine? And you'll be like, no, you're just going to kind of let that go because the patient's otherwise fine. So that might be an example of when you just do nothing. But for the most part, EM is a very active specialty. So we're often going to be asked to do things. And those things are in the ABCD. So often you can just go back to ABCD. Like in the last lecture, right? Like repositioning the airway. Like that would be the first step, right? Before you kind of even get into like airway and breathing, right? So that's what makes it, right? Now the killer gotchas, right? So anytime you bite on one of these gotchas, remember this list I talked to you about, destabilizers or gotchas. I would tell you that it's probably important for you to kind of keep that list. So, you know, here's a gotcha, here's what the definition or what it is, and then just like 3 things about that. And if it's in there, it'll be right probably one time. So a perfect example of a gotcha that people, you know, here, let me see if I have here's some great killer gotchas. So Lambert-Eaton, Guillain-Barré, right? So Guillain-Barré is like, it's perfect, right? It's a named condition. It's got neurologic, it's like a systemic infectious process. You'll see it as an answer choice multiple times. And so it's probably a good idea if when you're studying for your boards, if you see something, you're like, hey, let me put it down on my list, get 3 things I learn about it. It'll probably be one time. What about Lambert-Eaton? Y'all remember what that is?
I know it affects the muscles, like muscle weakness.
Yeah, right. So here's the thing, right? So it's like a tumor, but also has like myasthenia type findings, right? And so, you know, so you might be like, oh, maybe I remember something about that, but it'll totally mess you up when you're sitting there staring at it as one of the answer choices. So, you know, put it on your list, and then you learn 3 things about it, and then you got it, right? Some other kind of gotchas that, you know, where you have multiple systems involved, like pernicious anemia, right? So here's something where, yes, you got anemia, so it's a hematologic problem. So in addition to that hematologic problem, now you've also going to have like neurologic problems too, right? So you can get spinal thalamic issues, you can get corticospinal issues, you know, you can get dorsal column issues, right? So those are it's something to be thinking about. And then sometimes like older obscure ones, like if I throw strychnine as one of your answer choices, you'll probably be like, huh, could that be? I don't know, maybe. And so it's probably a good idea for you to just like look at strychnine and say, okay, what is this? How does it work? When would it have been, when would it possibly use? But like in almost no case would that be the thing. And it's something that you don't see very commonly now. All right. Gotcha. All right. So here's an interesting thing. If you don't have any clue, let's suppose you're like got 5 choices and you're like, I have no idea. I have no idea. I can't even eliminate one of the answer choices. Well, interestingly enough, it seems like in emergency medicine, choosing the answer choice B as a default may be strategically slightly better. And I'm going to explain to you why. So, obviously C is bad if it's true, false. But the reason why is because emergency medicine is an active field, and every one of the answer choices is listed in alphabetical order. And if you talk about like active verbs that they might potentially choose, a lot of them you start with vowels. And if you, this is kind of an interesting phenomenon, but if you put them and you alphabetize them, remember our vowels are A, E, I, O, U. So a lot of them is actually pushed more forward up higher. So interestingly, it might actually just be B because of the way statistically it'll fit. And so, questions, this whole thing with the med students kind of get things right. Like they choose like 20% or 80% as kind of the tails of like statistically how things happen. So that kind of leads you to B or D. So I don't know. There's kind of some interesting mojo about choosing choice B if you have absolutely no idea. Okay. And so here it is. Answers are in the affirmative. Action verbs are typically vowels, and answers are written alphabetically. All right. So let's talk about our approach, right? Learning your material, making sure you study for boards, practice, and then keep your eye down, keep an eye on like the countdown. So one of the things that I remembered for me is that you're always looking for the in-training exam, for example. It's always right at the last Wednesday in February. Now there's like a week where you can kind of get that in, but you want to try to prepare following up. That's why we're doing these ITE reviews before we get to our last Wednesday in February. And so hopefully you've been pacing yourself and studying kind of to meet that goal. So it's a marathon, right? It's not a sprint. Here's an interesting thing. This is really more for med students, but if you study where you get tested, that's actually been shown to improve one's test score. So one of the things I started doing once I started learning that was we used to have our exams in med school in a certain room all the time, started studying there. And what it does is it kind of takes away a little bit of that psychological barrier that you might have at that particular place. Now, you're not going to be able to go to a testing center and just like hang out there, obviously. But if it can help a little bit, and it's a test that at some point in life you may have to be there, take it there. And then also just like food, diet, exercise, that matters a lot, and making sure that you're regulating those things as best as you can. We talk about titrating any drugs of abuse that you might have. So if you're a big coffee drinker, like make sure you do all the normal things that you would do so that you don't get run into trouble. And then this is kind of a funny thing. It's like know thyself. Just like figure out whatever your focused persona is. So one of my colleagues was like the way he focuses himself on an exam is like he pretends like he's like having an argument with somebody, and so that's what keeps him like adrenaline going, focused, fight or flight. For me, it's like the teaching thing that I mentioned earlier. Like I pretend that I'm teaching somebody something, and that kind of refocuses me. Some people are just like Zen or just kind of keep it over. So know thyself, I think, is really, really important. All right, we talked about right before the test. Cramming a bunch of junk right before the test, probably not going to really help you. If you have to like make a long drive, that you got to be careful about that. So I know that my first time I took the exam, the writtens, um, I was just going from Philly to New Jersey, but it was like an hour and a half. You know, it was like okay, that wasn't awful. But you know, the next year, I just stayed there and just had like the 10 to 15 minute commute, which I think is really, really important. You know, dressing comfortably with layers is probably better, because if you're ever so cold that all you can focus on is being cold and that you're not warm enough, then that's a problem. You know, making sure you're as well rested as you can be, I think, is important. At the test, maximize your chances, you know, the questions you don't know by crossing off bad answer choices and using some of the strategies we talked about. Looking at your timing is really important. When I started, the first time I did it on computer, there were all these little highlighters and little check boxes and other things, and I was like playing around with all that stuff. And then I looked about 50% of the way because I had little checkpoints for myself. So create your own checkpoints. And I realized I was like not going to make it on time. So then I really kind of abandoned a lot of those little highlighters and those other types of things. Keeping your focus. One of the smartest things I think you can do is bringing wedding drops, especially if you're taking these long, long, long exams. So you're talk about like a 4 hour exam, 5 hour exam, 8 hour exam for boards. Having re-wetting drops or something that you can just put in your eyes, I think it just replenishes you and makes you feel great. Energy foods, I think, are great. So some protein bars, peanut butter jelly. I mean, that actually works well. You know, reviewing your answers, if it's appropriate. But if you are going to review answers that you've given that you don't know about, really hone in on it. Try to be as active. Really try to find like, okay, I think there's something wrong here. Let me see if there is really something wrong here, as opposed to just kind of like just kind of flashing them on the screen, because you'll not catch that mistake and you're more likely to just fatigue yourself out by doing it. All right. I just love this test fail. All right. Let's talk about some examples here. Let me see where we're at. We got like 20 some minutes. So here's what I want to do. I'm going to stop share for a second here. And I had some examples of some things for that were a little bit more med student, but instead I want to here, let's just pull up like our peer questions. So I'm going to do this and let's go through a couple of these questions and see if it helps. Okay, I think this is it. All right. I might be hard to see that first one. Yeah, I think the second one maybe you all can see probably better. I'm sorry if it like looks weird. These are just like copies. So okay. So I don't know, does anybody want to read the second one?
Sure. A 46-year-old woman presents with constant abdominal pain and associated nausea that started 8 hours earlier. She appears non-toxic and is lying still on the bed. Blood pressure is normal, pulse rate is 95, respiratory rate is 16, and temperature is 100 degrees Fahrenheit. Physical examination is remarkable for right upper quadrant and epigastric tenderness to palpation without a rebound guarding. Lab test result reveal elevated ALT, AST, and alk phos, normal lipase and total bilirubin, and negative urine HCG. The next most appropriate management step is, and then A is acute abdominal series, B is CT scan, C is general surgery consult, D is oral cholecystography, and then E is right upper quadrant ultrasonography.
So wait, Kevin, before you even give an answer, because maybe you want to like look at it again.
Sure.
You can see how like if you just sneak peeked the question, like the next most appropriate management step is, then you could kind of be like, okay, they're asking for me for a sequential thing, right?
Mm-hmm.
And then you know you're kind of just kind of quick perusing. They're like, oh, they're giving me a bunch of you know, got like 4 different tests and 1 consultation here, right?
Right.
So okay, so you know, what do you think,
So I think,
or what could you eliminate before we even get there? I mean, where because basically they're telling you that this patient with abdominal pain, right? Like So here's where the syntax logic can just bounce out at you. Like, okay,
Mhm.
non-toxic, still on the bed, vitals are normal, but there's that
Right.
maybe borderline temp, right? There is right upper quadrant pain, but there's not rebound or guarding. So they're trying to tell you that this is not some sort of like
Not like
acute
a
surgical
surgical
emergency.
emergency. Yeah.
Exactly, right? But then there are some laboratory findings that are a problem. So what is that? So can you eliminate some items here?
We can eliminate, I guess, C
Right, a
as like
general
the
surgery
next step, and we'd
consultation.
want to wait until if we saw anything on imaging, maybe we'd get them.
Right. So like if it was somebody had a peritonitis or something, then that would make an appropriate thing. But for the most part, also on our exams, they want to know what an emergency medicine doctor would want to do, right?
Mm-hmm.
So it's good, right? So we can take that out. So basically now the person's pretty stable. So you're sending them to some sort of examination, some sort of test. What do you think? What anything else you can rule out from these other ones?
Maybe the D, the oral cholecystography.
Yeah, what is that? I don't know.
Right.
like,
Yeah. That's
like so
so I
right,
figured it's probably
but it's
not the right.
right, but so it's there to destabilize you. You're like, wait, what
Yeah.
is that? So yeah, maybe you throw that on your list of like, what are cystographies, right? Okay, great. What else could you eliminate potentially?
Um,
Like maybe A, right? Like the
yeah.
X-rays, right?
Mm-hmm.
Like we're not going to use X-rays for this part, right? So it kind of comes down to CT scan versus the right upper quadrant ultrasonography.
Right.
So what do you think?
I think I would get the uh right upper quadrant ultrasound, but
Great, and that's the right answer, right? And so in this case, this patient's basically kind of having cholelithiasis, right?
mm-hmm.
But you'd really want to see, where is that stone, or are there other true findings to make you get worried about should this gallbladder be out, and are they more towards the pendulum of biliary colic or more towards the pendulum of the cholecystitis, right? So I think that's important, and that's one of the things that you can see with the right upper quadrant. So is that kind of helpful to kind of like when we kind of tear down the question a little bit and break it down a little bit?
Yeah. Thank you.
All right. Okay. I don't know, Lupe or Ariana, would you want to take 3?
I will probably do the one after that because I'm in a little bit of a noisy place. So yeah.
Oh, okay.
Okay,
Ariana, want to try it? Yeah.
I agree. A 57-year-old woman with a history of metastatic breast cancer presents with progressive chest heaviness and shortness of breath that is worse when she lies down. Vital signs are blood pressure 110/55, pulse rate 135, respiratory rate 28, temperature 37 Celsius. Oxygen saturation is 91% on room air. Lung examination reveals decreased breath sounds on the right side with dullness to percussion in the lower 2/3. What is the most appropriate initial step?
Okay.
Oh, do you want me to read through?
Yeah. I mean, yeah, we can break down and again, one of the things that I always find frustrating in all of these exams is in emergency medicine, we do things in parallel, not in series. But they will always ask you like, what is the series question? But anyway, sorry, go ahead.
A is administer a fluid bolus of normal saline 500 mLs IV. Send blood for CBC, electrolytes, and cultures. X2. Give ceftriaxone 1 gram and azithromycin 500 milligrams. B is obtain ABG on room air. D dimer measurement and duplex scan of the lower extremities. Administer enoxaparin. C is obtain stat 12 lead EKG, give nitroglycerin 1 unit sublingual, aspirin 325, metoprolol 5, call for cardiology consults. And D is provide high flow oxygen, give nitroglycerin sublingual and furosemide 40 milligrams, insert Foley catheter. E is provide high flow oxygen, obtain portable chest x-ray, perform right thoracostomy.
Okay. So this question really is trying to get you to like figure out what this patient has, right? And so, Ariana, can you eliminate or sort of like what's your thought process about some of these answer choices?
I feel like these questions are trying to get us to do like ABCs, like the
Mhm.
ED steps. So I probably wouldn't do anything that would take a long while.
Good, I like that. So like, what could you eliminate then?
Mm. I feel like I would eliminate B.
Okay. Well, I guess actually here, let's this is kind of like one of those like, do you know what the diagnosis is? Right? So I think that's the thing. So like if you look at A, what are they leading you for A for the diagnosis? What are
Pneumonia.
yeah, pneumonia, right? Community acquired pneumonia. What about B?
PE.
Great. What about C and D? I mean,
Uh,
C is actually different. What is C?
uh,
We don't do the
heart failure.
metoprolol 5 milligrams IV anymore,
Mm.
but we used to back in the day. So this is like just ACS, like ruling out MI. Okay. D, you're there. You were just about to say it.
Heart failure or fluid over.
Perfect. Yeah, perfect. Heart failure, right? And then what is E?
Pleural effusion.
Perfect. Okay, so 5 different clinical entities. Okay. So actually, I agree with you in that you want to think ABCs, and that's usually like my great end around. But like here, it's like, oh wait, here's 5 different things. Like here's 5 essentially managements for 5 different diagnoses. So now you can kind of go back and be like, well, what do you think this is? Like, do we think that this is heart failure?
I don't think it's heart failure because it's
No.
unilateral.
So you can take D out, right? Do you think this is ACS?
I wasn't thinking that when I read it.
Okay, good. No, I don't think it is either. So I think the cardiology things you can take out. Okay. So do you think this is pneumonia, PE, or like a pleural effusion?
I think they were hinting towards effusion.
Perfect, right? Because it's like it's worse when the patient lies down, right? When the fluid's going to layer over. There are some bad things, right? Like the person's got a horrible shock index here with a pulse rate of 135, that systolic blood pressure with 110. I mean, this person's not in great shape, right? And the SAT's low. When I first started reading, I don't know if you thought this, but like I thought cancer, tachypnea, tachycardia, hypoxia. I was thinking about PE, and I think that could have been something to get you. But then as you're reading a little bit more and they're talking about dullness to percussion in the lower 2/3, that's when you're like, oh, well, that's fluid on the exam, right? And so hopefully that popped out to you from the logic. So your answer would be what?
E.
Yeah, E. Provide high flow oxygen, obtain portable chest X-ray, perform right thoracostomy. That's the correct answer. Excellent. Great. Lupe, what do you think about 4? If you're okay.
Yeah, I'm in the metro north and I'm gonna get off for the next stop, but is that okay? I'm gonna read this.
Yeah.
Um,
Let's see if we got you. If not, then we'll just have Kevin or Ariana jump in.
okay. Alrighty, 68-year-old man with a history of COPD, presented with hypotension, abdominal pain, and confusion. He's recently discharged from another facility with his long-term prednisone prescription and new prescription for azithromycin, but he admits that he did not have benzos. Vital signs are blood pressure, he's hypotensive, 89/48, pulse rate sympathetic to 110, respiratory rate 24, temperature is 97.5. Lab results with sodium of 125, potassium of 63, 6.3, and glucose is 55. In addition to fluid resuscitation and glucose replacement, immediate management. So that's immediate management should include. So he didn't. So there's a gentleman that has been on long-term prednisone. So he's adrenal suppressed, which are the key things. And he was saying that he didn't feel his prednisone. So now he is, um, um, now as a result, he's having all these electrolyte abnormalities and is hypotensive. So before I look at the answers, my initial thing is I just want to give him what he needs is some kind of steroid that's going to sorry, reverse what's going on. And it's
Right,
not
right.
just
Well,
gonna be like such basic amount.
what's the diagnosis, Lupe? What do you think it is?
So he's adrenal suppressed. So, and in addition, he's sick.
I mean,
So
he's
that is,
hypotensive tachycardia, right? So he's in shock.
yeah, he's in shock. He's in shock, but there's two things going on. His primary diagnosis, and then the other thing is like not being, and then having, so in other words, he needs stress steroids, is what I'm getting at. He's in shock because he's sick, but then also he has his steroid. So that's the answer that I'm gonna look for when I go look for my answers to tell you my thought process.
Okay, perfect. So what can you eliminate then?
So I could eliminate A, abdominal CT. So like he's unstable, he's not gonna go anywhere.
Right. You never send him. You go to scanner and you die, and we're emergency medicine, so probably unless it's an emergency surgery that the person needs, we don't get surgery involved. They want to know what we would do. So A, for two reasons, A is wrong.
Yeah. And for that same reason, well, for some reason, we're not going to get E.
Perfect.
I don't need a single consultation right now. Going back to B, I'm going to give this gentleman a special steroid, and I don't give ACTH. And it might be one of those distractors that I'm like, whoa, would I give this? I don't know. But the answer is I wouldn't give it. I normally don't give it. And so I think it's between C and D, and I think I'm gonna give the hydrocortisone 100 milligrams of D.
Yeah, perfect. So that's the right answer. So another thing too, you can be like, oh, three of these are the same. So it seems like they're leading me towards a treatment medication. And then you just got to know that, like, okay, well, hydrocortisone 100 milligrams, that's the adrenal crisis dose, right? And so that's exactly what this patient has. This is not just adrenal insufficiency, which is what we often see. This patient is now shock with these findings of the low sodium, high potassium, low glucose, right? So yeah, perfect. Hydrocortisone is the right answer. I've never given ACTH and I've never given glucocortisone. So these could destabilize you. And so one thing you might want to do is you might look at this and go, hey, when do I give ACTH? When would I give fluorocortisone, right? So that might help you for a future exam question.
Yeah, exactly.
If this person's just in adrenal insufficiency, as opposed to, the hydrocortisone, as opposed to crisis, which is when you're going to give this, right? And the reality, I know they talk a lot about not disturbing that, you're getting dexamethasone and not disturbing the ACTH stim test or whatever, right? Obviously, in this case, it doesn't. Or giving, sorry, if you give hydrocortisone, you can disturb that test, but when you're shocky, it doesn't matter. You want to give that, and the dex might be the one you give. So, I mean, there's things to look at here for your future test questions. Okay. Kevin, what do you think about 5?
Okay. It's saying which of the following abnormal test results is the earliest indicator of biological damage for whole body penetrating irradiation? I don't know.
So we talked about this before, is that this is like a fact question, right?
It's like, do you know it
So
or
this is
do you
kind of like,
not?
do you know it or do you not know it? But could you figure it out?
Maybe like whichever has the highest turnover, I guess.
Boom, there you go. So like, what if all these molecules were not just like hematopoietic molecules, right? So you might be thinking, like, if they give you like liver, kidney, blood, like stuff, you're like, right, like, sorry, I mean lung, kidney, and blood, like lung stuff moves faster than does blood or kidney, right? So like maybe that, but in this case, these are all parts of your hematopoietic system. So what turns over fastest or faster?
Not 100% sure. Would you have lymphopenia?
So
Or
that's the right answer.
yeah.
So great guess. I'm gonna give you that, Kevin. That's great. I mean, the hemoglobin, that does take a little time. I mean,
Right.
we never talk about eosinophils other than with like parasites or allergy, right?
Mm-hmm.
And so that's hopefully where that would be taking you. Your platelet count, I don't really talk about platelets necessarily as one of the things, but again,
But
we
they're
don't
like
really talk about
turnover,
whole
would it
body.
be? Yeah.
Yeah, but white blood cell counts we do talk about,
Mm-hmm.
So it's like leukopenia versus lymphopenia. And so I could easily see you kind of, or anybody just kind of sitting there going, oh God, which one of it is between the two of these, right?
Right.
Um,
I kind of like flipped a coin between the two, to be honest.
right. And that's when you read it, you're going to know that like radiation destroys lymphocytes and stem
Mm-hmm.
cells, right? And so the key here is a rapid decline in lymphocytes, and that's how we try to see. In fact, we try to see that at 8 hours. And if a person has, a lymphocyte count that's less than like 1,000 at that time, then that's really bad. Then they look at 48-hour time points. So they look at 48 hours for like a second measurement. So, I mean, again, that's not stuff that we're going to necessarily be doing in the emergency department. But if you start reading about these environmental emergencies, that's where, this is an important thing to know. Like the timing is really good. And then what organ systems get involved. So great. You got it. All right. Ariana, let's do question 6.
The 23-year-old man presents holding both hands over his left eye. He was playing basketball when another player hit him in the eye. He is able to cooperate with the examination, figure 1, and reports decreased vision. The definitive treatment option in the emergency department is A, carbonic anhydrase inhibitor, B, gentle pressure to reduce the eye, C, lateral canthotomy, B, observation pending ophthalmology consults, and E, thyroid stimulating hormone level measurement.
So I know it's a terrible photo, but sometimes they give you just terrible photos. But can you see that this is the patient's eyeball here?
Yeah.
All right. All right. So what do you think? I mean, what are the answer choices trying to get at? So like, what is A?
A is glaucoma, I believe.
Right, the acute angle closure glaucoma, right? What about B?
I'm not sure.
Yeah, I mean, I'm not really sure either. Like, reduce the eye, like it's like it almost sounds like it's like was like out of the socket, or maybe it's gentle pressure because the patient has a CRAO, maybe, like maybe they're talking about massaging the eyeball because the patient has that, maybe that. So maybe they think, oh, you think it's like out of its socket or something, and maybe that's what they're talking about. Okay, well, what about C?
C, I think, is like orbital compartment syndrome.
Right. So from a retrobulbar hematoma. Okay, great. D.
Like I guess like a more minor concern.
Yeah, I mean, and again, it goes against, right? Like we are an active specialty, right? So you're not likely going to get an ophthalmology consultation if this person is potentially having a, organ destroying process, right? And then E, what is that for?
I think that's like proptosis from Graves.
Right, exactly, right. So, so that's not what the thing is. All right. So what do you think the answer is here?
I think it's hinting like trauma and like vision loss, emergency. I would do lateral canth.
Yeah, perfect. Right. So that's the right answer. So, so in this way, kind of getting to the key here was the definitive treatment option. Okay. So, that's another thing that's important. So, like, even in acute angle closure glaucoma, sure, we can reduce it, but often they might have to go in and trephinate, the ophthalmologist might, in order to like get some of that fluid out. Right. So, that might not be the definitive management, but it's probably the most, we can do that. We can give timolol, we can give, you know, a cholinergic medicine. We can do some other types of things, right? But yeah, this is one of the definitive things, lateral campotomy, that we really can do. So I think that's another thing. Anytime you see the word definitive treatment. So there are times too where you'll be sitting there looking at a patient who's got alcohol poisoning, you know, or like like a toxic alcohol poisoning, and the definitive management is dialysis. Okay, that's a definitive management. But yeah, sure, we can temporize and hopefully reverse things over time by either giving 100% alcohol or giving fomepizole. But definitive management is actually the other. So it's always important to know what the definitive treatment option is. That's great. All right, here, I'm going to stop share with this, and I'm just going to go back to just sections of the talk. I thought you all did really great with that. Was that helpful? I mean, I hope that's you know, kind of good to break down some of those things. Obviously, when you have a lot more time to think about it and look at it, it's really easier. But here, let me pull. Let me see where I was going to try to get to. No, I mean, basically, sorry. I guess that's basically the end. My last slide was, my last kind of 2 slides were just the following. So, okay. Yeah, I mean, that's basically the talk. I think as long as you try to decipher what they're trying to get at, and if there's a pattern that you can recognize in the answer choices, and then maybe keeping those logs for all of those kind of tricky either destabilizers or gotchas. I don't think we did a question where it necessarily had like a gotcha answer choice, but I think that's something to keep in mind when you're going through these, because trust me, the test writers, I'll tell you, it used to take me like 4 to 5 hours to come up with one question. And like to that level, when I had it like in my mind tested, and even then they would go through testing after that. So it took a long time because you're trying to find the exact perfect wording and the exact perfect thing that you could put in there to you know, to be wrong or to potentially trip somebody up. So not that you're trying to do it in a sinister way, but just, you know, trying to come up with a nice question that way. So I think you're all going to be ready. I'm wishing you all wonderful luck, and you got all of the support coming from all of us as faculty for your in-training exam and then ultimately for your boards. So thank you very much. Wonderful
Thank
getting
you.
an opportunity to share time with you.